think we should make a start of it. So welcome one and all to what is the second board meeting. Now, we've decided to truncate this meeting today in the light of the weather. And there are two reasons for that. The first is that a number of people in the room may have to leave and go and deal with whatever's developing in terms of staffing and whatever. So if people around the table get up and go, that's why they're doing it. They've got to deal with an urgent phone call, and I think you might as well, Sophia, is that right? Yeah. So people around the table, Sophia, that might have to leave to go and deal with various issues. And the second reason, to be frank, why we've truncated is that three of us have got to get back to the UK tonight, and so we felt the longer we left it, the less chance there would be. So those are the two reasons. So we've shortened the agenda somewhat. We left every item on with one or two exceptions, but that's the way we intend to handle the fact that the inclement weather has suddenly arrived. So are there any apologies?
There are. We have apologies from Kathy Stone and Simon Mackenzie from the Change team and Chris Bell.
Good, thank you very much. So just in terms of the way we're arranged and appointments to the board, so on this table at the top, the U shape, what we've agreed is that when the board is fully formed, there will be a chair and 5 other non-execs. Of those, the chair is yet to be appointed. That process is underway, as I understand it. And the 2 non-execs names will be, 2 further non-execs names will be announced when those appointments have been made. In terms of the voting directors, there are 5. There has always to be 1 less voting director than non-execs, 6 non-execs, 5 voting directors, and they will be chief officer, medical director, chief nurse, HR director and finance. So it's a standard setup. I don't anticipate, though I certainly won't be chairing it, I don't anticipate votes. I don't think I've ever seen a vote around a table like this. And so the difference between the people on this bit of the table and that bit of the table is pretty arbitrary, to be frank. And it's just to make the point that we are conforming with good practice and having 6 non-execs, including the chair and 5 execs. In terms of the chair role, then, as I've said, the appointment process is, I understand it, underway, and this will be, in all probability, my last board. So, there's a couple of things really. I want to wish you all well in your future endeavours. The purpose of this board, as we've said repeatedly, is to serve the people of Jersey and to provide the best possible health care and social care that can be provided in light of the available resource. So firstly to wish you well, and secondly to thank those of you that have personally supported me in setting up the board, and perhaps most notably UN. That's where we are. This is probably my last board. There will be, I imagine, a new chair in the seat next time, and hopefully the full complement of the board will be reached, so that there will be a chair and 5 non-execs, and the exec appointments will be clear. So one of our new non-execs, who can't be with us because she has just returned from Australia, I think is off to Belfast, is Claire Gerarda. And Claire is, do we have Claire on there?
The internet just dropped out.
We've got the usual technical problems. So when Claire has joined us, I'll ask her to introduce herself, as I did with the other non-execs last time. So, are there any declarations of interest? Minutes of the last meeting. Well, these are pretty fulsome, and all of the action points will come to in the action tracker. So we sorted out the action tracker, so we've got a list of actions that we agreed we would do at this time. So everything in the minutes that needs to be brought forward to this meeting has been brought forward. So given that, rather than go through it page by page, I'll assume people have read the minutes. Is there anything anyone wants to raise from the minutes?
No.
Tony, yeah.
Is that matter arising or accuracy?
Either, yeah.
Okay, well, an update on matter arising. Please say Andy and I had a good meeting last night. This is to do with the action on page 8 about the suite of metrics for social care. But obviously they're not enough and they're not well focused at the moment really. But we're very committed to developing a suite of indicators which is genuinely about what this board is trying to achieve from the social care and community strategy side, Andy, we were talking about, weren't we? So we're looking forward to working more on that and reporting back to the board.
Excellent, thank you very much. The inevitable question is by when?
Sorry?
By when do you hope to have done that?
So I think there's 2 steps. We said that we want to try to get some additional or different KPIs for social care in for next year. So we anticipate that will be done in the same timetable as the normal KPI setting, so by early December at the latest. That won't be the full after work that we want to undertake. That will take longer, so that will move into next year. We think there's some initial things that we can do for next year's KPI, unfortunately.
Right, so this is going to develop over time, by the sound. Yes, Tony.
I think as Andy saying, I think if we can focus on getting in the short term a more coherent set of KPIs, and then we can in effect dovetail that with the development of a clearer, people-focused strategy.
That's great, I mean, good.
Yeah.
Okay. And I guess the sooner the better, really. So we've got some better measures. And will those KPIs be able to be benchmarked against performance of other similar organisations, or is that too difficult?
Some will. So you'd anticipate we'll have the same issue that we've got with some of the health KPIs, that some of them will be easily translatable and benchmarkable, some less so due to configuration, legislative difference, etc. But we'll make sure that when we describe KPIs, we're clear what we can benchmark against.
Good.
Yeah, Hugo, to add to that, I mean, we want everything here to satisfy the so what.
Yes,
So
absolutely.
Yeah.
So that's great, and I think the more that can be benchmarked, the better would be. My view, so that will help people like myself who may not be familiar with the KPI to see it in context. I think context is crucial. So good, thank you very much. Anybody want to ask anything about that? No. Good. So Claire is back, I think. Are you back with us, Claire?
Yeah, thank you very much. There was some glitch.
So, no.
Yeah. Did you just want me to introduce myself?
If you'd be kind enough
So-
to do that.
Yeah, so I'm Claire Gerarda. I'm a GP and a psychiatrist by training. I have links with Jersey in that my new daughter-in-law is from Jersey, is from the island. And I hope to bring to the board an expertise of working in the healthcare sector for about 40 years at various positions of authority and various positions of expertise. I'm also have been head of my profession at the Royal College of GPs, and I'm very, very excited to be on the board and really look forward to meeting the other members, the executive members, but also members of the public. And I've already been in touch with some of the GPs on the island to get a sense. I know this board doesn't have a jurisdiction over primary care, but just to get a sense from the other end of how patients are experiencing the services on the island through the lens of the GPs, but also I'd quite like to get it through the lens of patients. So thank you very much.
Thanks very much, Claire, and welcome. Claire, as with our other non-execs, has had and is having a distinguished career. So I think Jersey is very fortunate to have quality non-executive directors that we've been able to attract. And I'm sure those that are yet to be appointed will be really good. So that's very reassuring. So Chief Officer's report now. Chris is away, and having been through the Chief Officer's report, I think the issues in it are all covered later in the agenda. But if there's anything in the Chief Officer's report that isn't to be covered later, then please raise it now, yes.
Yes, there are plenty of things in the report which
Yes.
do need covering later, but the one thing that I didn't think was necessarily is the Be Heard survey, which you refers to in the report, and I think it would be really helpful for us as non-execs to get a copy of the results of the Be Heard report. And I would be very interested as well to know how many staff have referred concerns so far through the Guardian.
Steve?
So Cheryl is leading on Be Heard, and I'm sure it's very comfortable sharing the information with the non-execs,
Yeah, more than happy to.
so we can get that to you.
Thank you, that's fine, thank you.
In terms of
About the
the
Guardian as
Freedom
well.
to Speak Up Guardian, I can't give you a precise figure, but it's greater than 20.
Oh, so it is being used.
Yes, I think that the Guardian we've appointed is very impressive, and that she and I meet at least fortnightly.
Oh, that's good.
So that the view I've taken of this is that the Freedom to Speak Up Guardian should have immediate access to a non-executive director. Given that I was the only non-executive director, that's me. But that's something that could be discussed. I'm not wedded to the idea it's the chair. But I do think it's important that it goes straight to a non-exec. We've worked out a process by which Ashling and I refer the issue to an executive director to deal with it, and then seek a report from that executive director. And my impression so far is that it has proved already valuable. I think will be very valuable.
Okay, that's really good to know. I know it works really well elsewhere,
Yes.
and the independence is really important. So I completely agree with the reporting to a non-executive, without a doubt, and I think we should maintain that. It would be good, I think, for this board to see a report from the Guardian in one of our future meetings. I think that would be very helpful.
Yeah, indeed, and we're working on that. Ashton and I have discussed that, and she is producing a report which will be more around themes, of course, than around individual cases. So to go in the public domain will be a report about the themes that are coming to her. And then if the non-execs want to know more about the detail of any of that, that's probably for the private part.
Yes, I agree. I agree.
would
Yeah,
suspect.
thank you.
So that's how I see the process evolving. So thank you for that. And if you've more thoughts, then
Yeah, happy to.
please let me know. Thank you. Anything else in the Chief Officer's report? Right, then let's go back to the action tracker. Deal with the issues that we have on the action tracker for this meeting. And just take them one by one, and the indicate prosecution policy will be available.
So I think that we're hoping to have that ready for ratification in January.
So that comes on January board, will it?
No, it will need to go through the ratification process first before it comes to the board, so I'd suggest the following board would be the best.
Okay. Who ratifies it?
There's a policy ratification group.
Right. Now we discussed this before, and I think what would interest me and the non-execs is precisely what the function of that ratification board is. Because last time I think Patrick was hinting that somehow this board was going to ratify NICE guidelines. And maybe I got confused about that. I'd be delighted about that. So who can come back and explain to the board what the ratification board does? Who's in charge of the ratification board? That you, Patrick?
For policies?
Yeah.
Yes.
Right.
So the role of that is it's not to write the policies, it's largely, well, it is to provide oversight to make sure that there's been consideration of policies that may affect more than one care group or one area of the organisation. Consideration has been made around that.
Right. Okay.
And simply to ratify the policy, but not to review it and critique it.
Good. As long as that's absolutely clear. That would be great.
Yes.
Good. Any happy with that?
So just to clarify, we cannot ratify policies. That's for the profession to do.
Yeah.
Yeah, thank you.
Good. So, Patrick, you're next on
Nice guidance.
guidance.
Yeah, so the quality and safety team are prospectively as new NICE guidance coming in, ensuring that it's distributed to the appropriate area of the organisation and seeking assurance that it's been followed. It's been monitored and will be monitored through the new care group governance reviews, which have started since the last board meeting. There is a work to do looking back at NICE guidance to ensure that it's compliance, but that's quite a big piece of work because there is a lot of NICE guidance, obviously. And moving forward, what will be helpful is when we implement the new electronic system for monitoring policies and guidelines, that will have a facility to maintain record and oversight much better way of NICE guidance moving forward.
Thank you. Do you have any sense of whether or not following some of the international guidelines is now more welcome than it was?
Oh, absolutely, yeah.
This is ceasing to be a contentious issue.
Yes, I think as we recruit more new colleagues who've grown up in the system or been trained in the system in the UK, they're much more used to following that guidance and using it. As we've talked about before, NICE isn't always most up-to-date guidance, but we have had, I think, 2 requests for exceptions to use other guidance, such as European guidance. But no, I think that I don't get a sense that people are resisting it.
So the line I think that you and I have discussed, Patrick, on this is that if NICE guidelines, if there are better internationally recognised guidelines, then that's acceptable. If for any other reason, and there might be perfectly legitimate reasons why those guidelines can't be followed here, then that comes here to the board.
Yeah.
So through the board, therefore, the public of Jersey know that this internationally approved guideline is not being followed in Jersey, and they know why it's not being followed. You should contend
Yeah.
with that. Yeah.
And just so I think Claire has been texting to say that I think this is an area which she has keen interest in
Yeah.
about who sets the guidelines and how we ensure that guidelines are properly followed and adopted.
So all new guidelines have to contain an explanation of how they'll be audited. Again, as a retrospective for all the guidelines.
Yeah.
Goes in.
So, Patrick, would it be reasonable to say, perhaps, could you come back in a couple of months and just tell us where we are with the new guidelines?
Yeah.
And to what extent you can assure the board that compliance is occurring? And the same, Jessie, with those that apply to the professionals, so that we have and then over time we have to work back through, as you say, there's a huge backlog. But it would be really helpful to know that at least those who are new are being applied and complied with. So perhaps a couple of months' time.
Yeah, we hope that the new system that we use to manage all the policies and guidelines will be in the first quarter, so I think absolutely have to come back in January, but we'll probably be providing more reliable information moving forward from there.
Good. Okay. Thank you very much. Anything else on that? On this, I think this is a really important step. Well done. Work for implementing it. So the next, Patrick, you again is a date, I think.
So this is the general surgical one. We have had a discussion in the last week with the Royal College. We're in the process of agreeing terms of reference for that review. The Royal College will then have to put a team together, and they estimated that from agreeing in terms of reference, which hopefully will happen in the next couple of weeks, to them coming in is likely to be about 3 months. So probably towards the end of January or February time next year, a team on ground.
Okay, can you update us at the next board? And hopefully at least by then we'll have the terms of reference.
Yeah.
that consented board. Anything else on that? Okay. Jessie, I think pick a survey.
Yes, so the PICR survey has commenced and is due to be completed with all survey forms returned by the 19th of January. So I would anticipate that getting turnaround from the PICR Institute and pulling our data together, we should be able to bring a report back to the board by March.
Okay. Happy with that? We can't do it before that, really.
Well, it's just we have delayed the closing date due to it coming up to the Christmas period, and also problems of with the mail getting back and forward to them. So we want to ensure that we get as many results as possible.
Okay.
I am in constant contact with the PICR Institute, so I have weekly meetings. So I can come back to the December meeting and get a further update to see if we can pull it forward to February.
If you could. Have you seen the previous PICR report? Caroline and Tony, have you seen that report?
No. So
We'll get that. It was, I thought, it was quite an encouraging report,
Yes.
wasn't it?
Very good.
So, yeah, Claire. You want to
Can I
see?
just ask a question?
Yes.
Well, there was a PICR report in the papers that was sent prior to the interview. How is PICR going to drill down to the real granularity, for example, of concerns we're hearing about discharge planning? Because PICR, as far as I'm aware, do a sort of stratified survey. It tend to be people who are, in order to take part, they tend not to be the ones that are hard to reach, etc. So how are we going to capture some of the problems that we're hearing from patients around, for example, discharge planning, and I noticed that we still have serious problems with bed sores and things like that. So I just wonder, Chair, whether you could just ask how we're going to do that, whether we've spoken to PICR about that.
Jessie?
yeah. So
Thanks, Claire.
we've got 5 PICR are undertaking 5 surveys for us. The questions are based on CQC inspections, and we have added some questions that relate more specifically to Jersey to ensure that we get data back.
And are those questions available now?
Yes, they are. The letters, the surveys have started to go out, so the surveys are sent out by post, but there's also a link within the survey to encourage people to answer the survey online. Bearing in mind though that there will be people that don't have online facilities, that's why we've done the 2 options. The letters have gone out to 5,800
Right.
patients that have recently been in the hospital over the same time span that was taken
Okay.
from the previous PICR survey, so for the same period of the year and the same time span.
Right. But we could get those questions to the non-executive.
Yes, you can.
So Claire, we'll get the questions that are going to be used this time coming. My suspicion is they probably can't be changed for this survey. No, so they can't be changed for the survey that we're about to embark upon, but I'm sure they could be changed for the following one. So that we will get their questions to all of the non-execs, and perhaps you'd be kind enough, Claire, to look at them from that point of view as to whether you think they cover the issues that are important.
I'd be delighted to.
Good, thank you very much. Thanks, Jesse. So, Steve, is there any update on?
Yeah, so Emma kindly forwarded to me the email from Tony with his thoughts and comments, and I'm in full agreement with them. We have the opportunity now with some additional resource, working and resourcing, to start looking at person specs and job descriptions, and we'll do that. And I'm happy to have another conversation with you about exactly what you've seen elsewhere around that inclusive recruitment activity. We also are moving to a new onboarding system, recruitment system, which will give us the opportunity to look at where people fall out of the system and that attrition rate around reasons that people drop out, and promotions as another key example around our acting ups as well, where we need to be clear about, you know, the openness and transparency of those. So they're all things that were on the to-do list, as it were. But it's just finding the capacity to deliver them, and I think we're at that place now.
Tony?
Yeah, just to say thank you very much for that, Steve. And yeah, I mean, for what it's worth, I'm quite happy to be a resource on that. I'm not saying I'm the world's expert either, really, but between us all, I'm sure we could make some useful interventions. Yeah.
Thank you.
I have, in part of my other work, been engaged in some inclusive recruitment work, which is really trying to reach out to people in the community who wouldn't normally be coming forward, maybe need some support.
Yes.
So with training and development can make a real impact. So I'll make contact with how that's happening.
Yeah, please do.
Put that down as an action for me. Yeah.
Thank you.
Thank you.
So I leave that with the two of you.
Yeah.
Great, thank you very much. Next is this was Chris, I think. Yes.
I can give an update on that. So that's ongoing. So we are reviewing the metrics. We've also got a change team for going forward for next year. And timeline, I think was specifically asked for the timeline, is internally going through reviews, and it's supposed to come to board in January for sign-off.
Great, thank you very much. Happy? Yep. Andy?
This is the item that we discussed earlier, but
Yes.
something we're addressing in relation to KPIs. It's the same item.
Same thing, isn't it? Claire?
That's been done.
Done.
Yes, thank you very much. Board timetable is this, Chief Officer report. Emma, yeah.
So in terms of the estates and the new healthcare facilities, we are going to incorporate that into one of our board workshops.
So just to explain that a little further, what I think we've agreed, and I've agreed with the non-execs, is that there'll be 10 board meetings a year. That's all previously been agreed. And at the same time, on the day before that meeting, there will either be an assurance committee, so of those 10 days, 4 will be assurance committees, so quarterly assurance committees, hopefully the 3 assurance committees on that day. And on the 6 other days, there will be a programme of workshops, visits and whatever, and we're beginning to work out what that might be and what non-executives would like to do. If any of the directors have thoughts on what they believe the non-execs should do in those days, they'd be gratefully received. Because I'd like to get the programme into place so that we know what's going on for at least for the year. So if the non-execs can think about it on our WhatsApp group, and if the directors would give us thoughts on what they think is important. I suspect there'll be more than we can actually do, so there'll have to be some choices made. It would be really good to get that programme into place. And while on the topic, the 3 assurance committees, I think it's likely but not certain that those 3 will continue. And my hope would be that up until now, as you know, I've been trying to chair all 3, and I hope that will move now to a non-executive director other than the chair. So we'll sort that out. Good, thank you very much. Andy, is it you?
Sorry, Chair, I think it's an agenda item that's outstanding, so we were going to consider the electronic patient record on the future agenda as a whole.
Right.
Could we check in on that? Because, I mean, again, like the last meeting, the new electronic patient record was mentioned a lot, and it is in here as well. And, you know, in the Chief Exec's report, I didn't raise it at that point, but I was quite concerned the fact that ITU and ED have not yet been updated onto that system, which I can only see as being a safety issue. So could we please have something on that to the next meeting?
Claire, thank you.
Yeah, happy to provide, detail. The ITU and those areas that you spoke of, they were not on so the phasing of rollout. So when the new electronic system was implemented in May, it was very much a like for like. So historically, there'd only been 2 areas in HCS where actually the electronic patient record, as in terms of medical notes being put onto the electronic system, was in place, and that was actually in ED and maternity and AAU. So what was actually switched on, if you like, was a pure like-for-like, which was more of a patient administration system in terms of patient bookings, etc. And then a phased rollout over the next couple of years of different modules coming online at different times, and then allow, for example, areas such as critical care to have those areas. So the rollout's been as planned, but really the significant benefits realisation from having a much better system will come as we now then get other areas put online. So we can work with colleagues in M&D to bring a sort of a full report. Happy to do that, but just to provide that clarification, so there's nothing that's affecting safety in those areas.
Thank you. Thank you. I think it would be good to get that. Thank you.
It would be.
Yeah.
Andy.
So just not to conflate the issues then. So this item is actually about the recommissioning of an electronic patient record for mental health, social care and community physical health services.
Yeah.
We currently use an alternative system. This is a formal government project that's going through the PMO process. It's at very early stages. We've been doing a load of consultation work looking at specification for the new EPR, particularly across social care, where we have issues around how information is shared. We've set quite a tough spec, I think, where we're asking for some very specific capability of any new system. For example, service users being able to access their own information, input into their own care plans, all the types of things that you'd expect to see in a modern EPR in this area. So we had a meeting yesterday, which was our first engagement meeting with the 2 people who have put themselves forward as potential providers. So it would be useful to understand what the board would like. This is a formal process that will go on for about a year until we reach the point where the award is given to a preferred provider. So at any point we can bring back updates against that process, but happy to be directed as to what you'd like to see in relation to that.
So for me, the issue is at the last meeting and indeed in this agenda, quite a few where we're not actually achieving, the introduction of the EPR is mentioned as a reason why we're not achieving our targets. So I think I'd be particularly keen to understand when we are going to, when that part of whether we're achieving our targets or not is taken away, and then we know whether it's something else more fundamental as to why we're not achieving our targets. Because at the moment, I'm sorry if this sounds a bit harsh, it's just cast out as an excuse for why targets are not being achieved quite liberally, and I think I would like to understand whether that is absolutely the reason why we're not achieving our targets or whether there are other reasons as well. And at the moment I think it kind of obscures on that. So I think it'd be really super helpful to get something soon.
Okay, happy to do that. Yeah.
Thank you.
I mean, obviously I can address issues, particularly as well in terms of the detail that we provide with those particular metrics. Obviously there are some, it has affected data collection processes. The previous EPR system was been in the organisation a very long time. Obviously, it's been evolved to support the organisation, and obviously what we've got is a off-the-shelf one which is now being evolved. We are learning from other providers in the UK who've got this who've got the system, which is helping. And so it has impacted areas, but obviously we're sighted on those. We're managing the risks. And working with colleagues both in M&D and the actual company to get them to where they need to be.
I'm sure that is true, and that you're doing everything you possibly can. I'm not for 1 second suggesting that you're not. I think it would just be helpful for us to see the full picture in relation to it all. Thank you. Yeah, thank you.
Could that be for next time,
Yeah.
Claire?
Absolutely.
Yeah.
Yes.
Thank you very much. Tony?
Yeah, building on what Andy's asking about what the board would expect from this, again, appreciating it's really complicated territory, business really, and confidentiality. So I love what you're saying about the contribution that people themselves can make to their own record. That's great really. I think our guiding principle needs to be what would make sense to the person, you know, him, her, themselves really, in terms of records kept about him, her, them, and to which they can contribute, as you say. Let's not, amid all the technical aspects of this, let's not lose sight of that founding principle, something that makes sense to the person we're trying to provide appropriate care and support to.
We've engaged actively with people that use services to ask them, what would you want us to see? And clearly, there's, you know, as you say, there's issues around interoperability between systems, around how we work across the system that's used in the hospital versus the system that's used in the community. But fundamentally, please be assured that we're being driven by what's the best system to deliver the best care for people in this context.
So, are you two liaising over this? Or will you liaise over it?
Of course we can.
Yeah, well, I think Tony would add something to your experience has been really helpful here.
Yeah, yeah,
So,
very much.
Claire.
Yeah, I'm sorry because I'm new to this in the EPR. I mean, I saw it in some of the papers. The EPR cost can spiral out of control. I just wonder, I mean, not maybe for now, but I'd love to be briefed at some point on what the procurement process is. You talk about interoperability. I mean, that's the sort of holy grail, is interoperability. Are we talking interoperability with the primary care system, which I understand is EMIS? I just want to know how the process is going, because having seen an EPR system being put in place at a very large NHS trust, it took about 3 years to procure, and then another year of training and just trying to get everything up on board. So not for now, but just because I suspect a lot of thinking has been done about this, but it would be useful, certainly I would quite like to know what the process has been and what the procurement process is and what the costs are and what the risks are in terms of cost spiralling out of control, and whether you're going to do a sort of find one off the shelf or build your own. It's a very complex area, EPRs, the whole system for a hospital organisation. So I just wanted to raise that.
Yeah, thanks, Claire. I think there are two complicated issues. One is the system, and the second is the procurement process in Jersey. And HCS doesn't necessarily, well, it doesn't do its procurement itself. It's done, as I understand it, through a governmental process. So my suggestion is that Andy, if you could produce a briefing on what it does and the interoperability, and Obi, are you best placed to talk about how procurement works in Jersey? Not today, but for another time. So to brief the NEDs. I think there are two separate things, Claire. Yeah, so we will get something from Andy on what it is and how it should work, and crucially the degree of interoperability. And Obi will brief the NEDs on how procurement works in Jersey, which is not the same way as it might work in the UK. Is that okay?
Thank you.
Okay, thank you very much. And I think one more we have on here.
We do, that's the last one, Chair, and this item is going to be covered in our workshop in December.
Yeah, so that's fine. Okay, we're going to move on in a moment, but could I just be remiss not to welcome the Minister to whom we account, who is sat there and will give us a little wave. Thank you very much, welcome. So let's move on to the quality and performance report, and we're going to concentrate, if you recall, on the issues that are set out here on the agenda. So if I could ask the various directors just to run through their bits of that would be great.
Thanks. So I'll go first, shall I? I think the so elective theatre utilisation, obviously I provided some detail in the report. Obviously this is an area that we knew had been affected by the implementation of Maxims, as the staff got used to working with the new system, and so there had been some areas particularly that we'd unearthed. For example, I think the year-to-date standard historically was 49%, so I think the board will be pleased to note the improvement that's described over the last 3 months as we've been able to improve our data collection. So I think it's a combination of a variety of things. The work that we've done to understand the data capture. So, for example, one of the things that we discovered was that our CPOD list, which is actually our emergency theatre list, that's a 24-hour list, obviously because it needs to be available so we can provide urgent emergency surgery at any time, was actually being collected in the elective theatre utilisation. So that's one of the things that obviously is now accurate, and also the steps that the staff are taking, both the members of our leadership team in terms of the head of access, working with our theatre sisters, managers, leaders, and clinicians, and obviously better capturing. There was actually 7 timestamps that the staff have to collect that are different parts of the theatre process. So, for example, the WHO checklist being completed, actually when the anaesthetic starts, etc. So there's 7 crucial stamps that have to be, a button has to be pressed. And so all of this culmination of work has allowed us to be able to demonstrate improved theatre utilisation. And I think also with the impact of the weekly 642 meetings that we're having, where we're actually assessing what our theatre utilisation is going to be in 6 weeks, in 4 weeks, 2 weeks, then next week, and then also looking back to see what we've done. So obviously we continue to have our eyes on the target and increasing, but I think it's good to see the progress over the last month, and obviously the impact in terms of the data. So I'm happy to take any questions on that particular metric. Shall I before I move on, Chair?
Yeah, so just setting aside the detailed process, what are the numbers that demonstrate that we've improved theatre utilisation?
So the discussions, I suppose maybe I need to bring more detail from the 642 meetings, but generally when we sit down to look at next week's theatre list, we're sort of in the range either 68, 74, 75% in terms of the planned list, and then we'll take steps with the clinicians who own those lists to obviously then book more patients, and then the week after we look back to see what was achieved. So maybe it's obviously this is the data that's then pulled to see what is overall over the month. But if we need to get some more detail from the 642 meetings, that might be a way of then bringing that in.
Yeah, I guess what I'm driving at is trying to get to an understanding of, can you give us a global theatre utilisation figure, or is that impossible?
Well, so this metric that we collect actually captures both public and private. And of course, HCS as an organisation doesn't actually decide, or that's up to the clinicians who. So that is contained within this metric. I think obviously we've got to a position where we're more confident about the data and our data capture, and then obviously we've got to work with the 642 meetings that are actually looking and reviewing and ensuring that we are booking those lists. I think obviously next month we'll have a bit more of a confirmed picture as we know those data processes have been improving. That is obviously what is really key is either clinician or individual list data as well.
No, I do understand that it's necessary to get all those processes right in order to have a reliable figure. But I guess what would interest non-execs most would be what is, at the end of all of that,
Yes.
what is the theatre utilisation for both public and private patients? Yeah? I do understand that the process is complicated and it needs to be improved, and it's good that it is, so I'm grateful for that. But I think what we'd like to see is what is the theatre utilisation as a single figure, yeah, without the preamble, if you like. So what is the theatre utilisation for both public and private patients? Would that be something that...
Definitely, yeah. I agree. We did discuss this with OBS today, because obviously theatre utilisation is absolutely critical to the financial recovery plan as well. So I think drilling down on this issue would be helpful to us. I mean, because at the moment, I know you say it's getting better, but the figures actually, from what I can see on the performance pack, are actually getting worse. So I accept your explanation, but therefore for us, when you look at it boldly, when we get these packs, you think, good heavens, this is just getting worse. How on earth is the financial recovery plan ever going to be successful when these figures look at that? And even in terms of the elective admissions that are private, even that is below target as well, isn't it? And that again impacts on the recovery plan. From my own perspective, I would be really keen to absolutely assure that public patients are being given a priority, and and decisions are taken on the basis of patient safety and patient urgency, as opposed to whether somebody is paying or not.
And I can provide that assurance in terms of our public patients are booked. Absolutely, it's around clinical, based on the clinical triage of the receiving consultant, booked in accordance with that. So perhaps this is a metric, Chair, that the board would like to see split out into public and private, and that's something that we could.
Yeah, the key issue is public and private, and what is the percentage? As opposed to what's the detail of the process that allows you to give us the percentage.
And perhaps some of the movement, the movement that we take in terms of the impact of the 642 meetings and some of that narrative could be brought in as well.
That's really helpful.
Okay, thank you. So,
just to add to that, Claire, as the financial recovery, we've been working very closely together. Clearly, theatre utilising is simply a measure of operational performance, quality, as well as the finance. The money just drops out. So we obviously work very. Just to give a bit of assurance, we have quite a detailed plan underneath this, and I think the metric doesn't reveal that because it's a very average of decades, main theatres. It just averages everything, so you only see what is the headline number. Underneath the thing, there is a plan that goes down to this level, and we are monitoring that. Of course, there are challenges in doing that, but we're working very closely with Claire and her team to monitor those. We have a baseline, there's an improvement trajectory. Of course, we've got to deliver it, and that's obviously what we need to see. We'll work on that.
Great, thank you.
thank you. Thanks, Amy. I think you and I would agree what we need is the numbers. So, Claire.
Thank you. Just so then it's on the same page as the QPR, I think the other metric that was discussed was the patients waiting over 90 days. So it's the predominant specialties that sit within that metric are community dental and physiotherapy. Obviously, it's pleasing to see that we continue to reduce the percentage of people waiting that length of time on our waiting list, and that's been predominantly driven by two things. The social COVID recovery bid that Health and Community Services worked on in SPP to secure additional funding so that particularly children could receive timely community dentistry with our community partners or with private dentists on the island. So that's gone really, really well. It's been a bit of a pilot, a sort of trial for us. So that's really great to see the impact that has had on the waiting list. Of course, there is risk in that this is a time-limited business case that we've received funding for this year, and obviously, once that money has been spent, obviously we need to see what the ongoing strategy needs to be for community dentistry, because the dental department at the hospital does not have the capacity to continue to provide community dental treatment for children, but great to see, and obviously that waiting list is now down to pre-COVID levels, so that's really great to see, and due to the hard work of the staff in that department. The physiotherapy improvements as well has been, we've got increased levels of staff there, we've been able to successfully recruit, and also we've done a sort of internal piece of work within the team too. We've been looking at the physios' job plans, and so those two schemes will continue to deliver those improvements. So any questions on that one?
Anything you'd like to ask?
Yeah, I think in terms of to dominate, but in terms of the waiting list, I mean, it is so red. It's just like a block of red, isn't it? So, and it has been now for over a year. and I know that waiting lists everywhere, it's not just Jersey, have been very badly impacted, so it's not an issue that's just specific to Jersey in any way.
No.
But I think, again, it would be really helpful to understand more clearly where specifically you are targeting to make a real impact. I think I asked last time, you know, how many people who have been waiting over that amount of time has that helped? We know definitely that their health has deteriorated. And I'm not sure that really had an answer to that. So I think for myself, in terms of assurance, I really would want to know how you are assessing. It's a bit like the theatre utilisation issue as well. How you are assessing the potential clinical harm to people as a result of long waits, and then how, therefore, those decisions get made in terms of prioritisation or otherwise. And I think it's purely an assurance issue, because I know that this is a real issue everywhere at the moment, without a doubt. So I think it's just for us as NEDs to be completely reassured that the decisions that are being made are on clinical priorities, really.
Well, I can, Chair, answer an element of that in terms of the waiting list recovery scheme that was developed earlier on this year. That was very much at the heart, Caroline, in terms of what were those areas that, one, carried the greatest clinical risk, and two, obviously where we had areas of the longest waits. So those were the pathways and the specialties that were put forward as part of that business case, and are the areas that we have funding to recover. So I can provide that assurance.
Lovely, thank you.
Any other questions on that?
It's just I think Claire alluded to the issue around dental, the community dental waiting lists. It is worrying because historically, going back quite a long time, the waiting lists were very long, and the only free provision for children's dental care was up to the secondary school age, and that was an arbitrary figure plucked because that's what the resource was at that time. This is going back long before any of us were here. So there's been, as Claire said, there's been an awful lot of really hard work to bring it down, but with the money running out, I think at the end of this year, it's likely that we'll see those waiting lists going up, bearing in mind that Jersey has signed up to the United Nations Charter for Children's Rights, and part of that is to provide free healthcare and dental care to everybody under the age of 18. So I think this is, as a department, this is something that's going to be very difficult for us to manage without support and without political support as well.
I wonder if it'd be helpful to get a more detailed briefing. Is this an area you're leading on, Patrick?
No, but I have been involved in it. I think.
Well, perhaps from the two of you on that specific, because it sounds as though there may be a funding issue. Yeah. So setting out what that funding issue is and what the implications are would be really helpful.
So I mean, we have measured in the past the number of permanent teeth being removed from children, and that I think has come down because it's in jurisdictions such as Jersey, it's trying to do that solution.
But I'd rather in a position to have those political decisions made about funding sort of well ahead of the event, rather than waiting until the crisis is upon us. So if you two could produce some specific briefing on that, that would be really helpful. Thank you. Anything else? New to follow-up ratio.
Yeah, need to follow up. There's some detail in the exception report in relation to some of the specialties. So I'm just finding my page. There we go. So as described, I think last month, we do see specialty detail at the monthly care group performance meetings. I've given some of the headlines of some of the areas that have been working to reduce those, some of the general work that we're taking forward around PIFU, which we know is a strategy that has improved and allowed us to move resource so that we can put more outpatient activity in terms of new, to have that capacity available to us. Obviously there are I know that this is a very broad metric, isn't it, in terms of the two, and covers a range of specialties, and clearly there are some specialties that it is absolutely appropriate where some of those patients would be seen more frequently in terms of follow-up, but clearly other specialties that we know that we can change our practice and divert that resource. So I've tried to give some of that detail there, but obviously something that we'll continue to work on in terms of monthly meetings with the care groups, and also is something that's sitting in one of the FRP work streams, and there's further detail in terms of those workbooks as Obi was describing in relation to other metrics.
Okay. Claire, I wonder whether it's... This is a big and comprehensive report, and I'm trying to get to the point where it's as useful to us all as possible. And I just wonder whether we should look at the same items next time with a focus on perhaps two things, or three things. One, what's the trend numerically? Secondly, when do you anticipate reaching the target? Yeah? And thirdly, picking up your point, Caroline, what do we know about the effect on patients? Yeah? So there's something for me about more numbers. I think the NEDs are probably more interested in the numbers and the trends and the effect on patients. And we'll kind of leave the processes to directors. I don't think I feel competent to comment on the process you're putting into place. I'm perfectly happy to accept you're doing your very best. But I think what we need to see is where it's going.
Yeah.
Would that be helpful?
Yeah.
Right, thank you very much. Finance report.
Thank you, Chair. Thank you. I'm going to highlight the key points for the month 9 finance report for the end of September. The year-to-date position is a deficit of 23.1 million, which is a deficit in month of just over 4 million. And our forecast deficit to the end of the year remains at 29 million. And I'll explain why we think there is mitigation against the current run rate of expenditure over the next 3 months. The main drivers remain the same as reported previously. In terms of staff costs, that make up a large proportion and overspend for to September and forecast to be 11.2 of the spend by the end of this year. The pressures are made up of premium agency local over expenditure being mitigated to the value of £24 million by the end of this year, mitigated by underspends in substantive staffing. And what that means is it is the recruitment difficulties and retention difficulties we have that means we have a dependency on temporary workforce that costs significantly more to provide the same care we would otherwise if we could substantively recruit those people. So that remains the major intervention. But that's what the numbers are telling us. We have that focus of the financial recovery programme, working with our colleagues to drive that recruitment is the only thing that's going to be looked at. And the other cost pressures, as the financial recovery plan, which was published, I'm pleased to say, earlier this month, and released, has identified a number of underlying factors. We all well rehearsed that, apart from recruitment retention. We also know that there are non-pay procurement challenges in the way we procure goods and services, and there are again plans to address them. What that drives is a £14.2 million investment currently to the year to date, which is going to be £17 million by the end of the year. Effectively, that is in what is the non-pay variables to budget. Underlying factors, number of them, we have a number of contracts that need to be managed more strongly, but also there are demand pressures on where we have had excessive demand in certain areas that we don't anticipate budget, in particular in areas like mental health and social care placement. And we also know that there is a lack of provision on that field causing a capacity problem, which means that prices can be charged pretty much what the market wants. And so we're not in control of that unless we have a clear intervention to try and change that dynamic, which is also one of the factors that the financial recovery plan describes that we need to do over the next few months. I guess what I'm describing is that what we will end up with is the 29 million deficit. Why? The identification of what the key factors are, what we are doing about it in the short term, but what will take some time to change. Finally, on income, which is obviously a key dynamic in Jersey, and in the way we provide services in healthcare and social care here, we are underachieving currently on income by 0.6 billion, but we expect to recover that position by the end of the year. The overall, one of the main reasons behind that is the lack of beds capacity in surgical care due to patients being in those beds who are beyond the need for them to remain there, which is again a capacity and flow issue that we have. Again, there is a plan to recover that, very clearly described yet again in the financial recovery plan, of how we intend to not only improve length of stay, which is the time people take to be medically fit and then discharged to a more appropriate setting beyond the need for them to be there, but also putting in additional beds capacity to help improve the flow in the short term, allowing surgical beds to be released back to surgery to do the theatres work and all the utilisation will be spoken about earlier, and drive income as well to help with the costs of running the hospital. And again, there is a very ambitious plan for next year to deliver income of almost £3 million next year to mitigate the costs of the additional beds forward once those beds are released. So that would also answer the question on theatre utilisation, answer the question on waiting lists, as well as help mitigate the financial pressures we're facing, which are simply a consequence of the inefficiencies operationally and quality that we described. Finally, to mitigate the position at 29, I think it's important for the board to understand, to keep the position at 29, our commitment is to deliver £26 million deficit by the end of the year, which we agreed with the Treasury, because as again the financial recovery plan describes clearly, that is a number that can't be recovered within 1 year, and therefore we agreed a 3-year plan, but over a 3-year period, whilst keeping the quality, improving the quality of care and keeping it at least the same, we will bring down the deficit, the amount of deficit that's in our control, which is 25 million of the overall 35 million that we identified, with Treasury giving us 10 million of permanent additional funding, and we're delivering 25 million over 3 years. But the board needs to recognise that to maintain that position of 26 million, currently I'm forecasting 29. I'm pleased to say that we have identified, working with the care groups who have been very active over the last, since the completion of the FRP, to deliver a £3 million saving this year. We have very good engagement. I feel reasonably positive that we will be able to do so, although I have not reported it in month 9. I hope to be able to report in a few weeks' time that we are expecting to deliver that £3 million in a year, which is a great achievement if we do that, to the care groups and the effort that they've made in engaging with the FRP, as well as all the quality improvements that we're having. So I cannot guarantee, but I'm positive we will deliver it, because I can see the light in doing so. However, to maintain the 29 position, there are other dangers here. So you will see the last thing that I've highlighted to the board is the reserves position. The reserves position has now gone down to 1.78 million. It has gone from what we had at 6 million when we started this year over the course of the FD. I would ideally like it to be 29 million. 10% should be our reserves, but you know, that's maybe in some time in the future to come. From a 6 million position, we have had to utilise our reserves to hold the position at 29, and then the 3 million that the care groups will have delivered. But what that is trying to say is that there are other cost pressures. That when you look at just the run rate being the difference between the income that we have and the expenditure that we incur every month. Differently, those two is what's called the run rate. When we look at our current run rate, there are pressures beyond that 29 million is what that's telling us. Because you can see that in month 9 we spent 4.2 million pounds. There's only 3 more million pounds we can spend to get to 29 million at the end of the year. 26 already. There's only 3 more million to get to 29. 23 at the moment. Sorry, we're at 23 at the moment. We can only spend another 3 million to get to 26, which is our commitment. And that means that the underlying pressure that we are managing, which beyond even delivering the savings, is 9 million on top of the savings we're delivering. That's the significant factor that I'd like the board to recognise. In other words, in simple English, that's in simple language, that means we're not delivering 3 million, we're actually having to deliver a 9 million pound saving to get down to the 26 million deficit. 3 million is visible because we know the schemes that the FRP will deliver. We can tell you, we can track those, we can monitor it. But there are other cost pressures that keep hitting us. That's the point I'm trying to make. There are other things that come out and just hit us that we have not anticipated, and no reasonable person would anticipate, no matter how experienced you are. That is a legacy of our financial operations and the operations of how care has been delivered and financial consequences. What I want to assure the board is as we identify those, we are managing them, we will deal with them, but despite the fact that the FRP recognised almost 95% of all the things, there is still an element that keeps hitting us that just is a legacy of how long it has taken for these cost pressures to be reviewed eventually. So, just to summarise, I won't use the word confident here, but I'll use the word I'm very hopeful that we will be able to achieve 26 million, but I'll report to the next board whether I'm confident we should have enough visibility then. But we have had to use a lot of reserves. We will hopefully deliver the 3 million. We've had to use a lot of reserves to keep our position at 29, and we're pretty much empty on the reserves now.
So just one question. So have we used the reserves in order to deal with those unexpected cost pressures, or are we using the reserves above and beyond that?
We are using the reserves for unexpected cost pressures that are arising, and then we are obviously looking to mitigate those going forward.
I understand that, but we're not using the reserves in order to make the position look better than it actually is. I'm not being clear.
Yes.
Yeah. So we're
Yes.
using,
If we didn't use the reserves, our underlying deficit would rise by £9 million.
Okay.
So we are using the reserves to mitigate that and delivering savings as well, which is part of the FRP.
Next month you'll tell us with a greater degree of confidence, hopefully, that we're on target.
The signs look like they're positive.
Okay.
I will confirm that because there are unexpected things that keep hitting us.
Thank you very much.
So I think I raised last time that I thought the level of reserves were extraordinarily low. And if you continue to have to use them because of unforeseen cost pressure issues, they're moving on in a month's time at this level of usage. And question therefore, so what happens then with no reserves? I come from working in a system where you would have to issue a bankruptcy notice if you were running like this. So obviously it's a completely different system. So is the NHS, a completely different system as well in the town where I'm in England. And so I know it's different, but actually that's pretty scary to only have that level of reserves. And then on the £3 million from care groups, I think that's great if that's been done, and that is a genuine efficiency. But I just think we need to be careful that it is a genuine efficiency as opposed to a cost reduction to that sector, because if it is a cut, then actually that will only impact adversely. It's like every cut to social care, in fact, impacts adversely on acute care. So I think if that's a genuine efficiency, really well done, and thank you to those organisations who've worked so collaboratively. That's brilliant. But I do think it's quite scary, given the cost pressures the unforeseen cost pressures as opposed to the known amount, and then the use of reserves to only have reserves of less than 2 million seems to me unsustainable.
It is, and I absolutely recognise that, and I think our discussions remain that as we come out of this year, the important thing is that we get our run rate, which is again, as I described, the difference between our income and expenditure on a monthly basis, comes down, and I think that's where we have some positive signs to do. So again, let's see what happens over the next 3 months. Once we do that, then I believe the tide has turned for us, and I think that's really the key here, which is why, whilst I'm saying I'm positive, I can't be confident, because the tide turning is entirely, of course, whether people buy into a plan that is being well constructed, at least that's the feedback I've had, well constructed plan, but ultimately it's about people believing we can deliver it. And once we turn that tide, that culture, then I think we are then masters of our own destiny. What that means for the reserves position, Chair, is that we begin to rebuild our reserves through the savings that we make. So that's the key thing. But it is a very, very, it is a very thin position that we don't have.
So,
Can I ask a question, Chair?
yes, sure.
Just, and if I've got this right, I've got figures here, the agency overspend, staff overspend, come to about nearly £35 million against an underspend of 17, and it's mainly agency. What's been done to mitigate against agency stuff? And I do understand that this is a universal problem, but it does feel for an island so small to have such an overspend on agency that somehow staff are maybe contracting themselves to the agencies, contracting themselves back to the system in order to get higher wages through agency, if that makes sense, i.e. doing their own locums. Is something being done to look at this? Because that seems an obvious area that can be worked on.
Yes, I mean, I would certainly ask my colleagues, Steve, Graham, Associate Director of People, to also contribute to this. But certainly from the FRP perspective, we've been working very closely together and with the care groups to understand what the recruitment delays are. And a lot of them there are process delays, but there are also the island factor of being able to recruit people to come to Ireland substantively is a challenge for all islands. But we have a number of programs now in place to try and do that.
Yeah, that's exactly right. So it's a really good question, isn't it? And I don't think there's any evidence of people who would have come substantively then going back to the agency and coming back. I think what we've got is evidence of people who've been long-term agency because there was quite a low activity in the recruitment market, and we got used to using agency, and we're switching that now to driving into substantive recruitment at a bigger scale. And you'll see in the report we're going to talk next that the last month has been one of our biggest hits in terms of bringing in new people, because we have multiple strands running now rather than just putting everything on NHS Jobs and gov.je. So I think what we're seeing at the minute is we're recruiting into roles that don't actually have agency in them, because the agency workers tend to do the really hard to fill roles, but the whole focus is to get that agency down and replaced with substantive, and there is, as I say, multiple streams going on in that area.
Claire, my impression of this is there's far greater proactivity than there was, but that it remains a very difficult and expensive area.
Also, to give you a bit more assurance, one of the major financial recovery programme interventions is exactly this.
Yeah.
So there's an absolute laser-like focus on how we can improve this.
If we don't succeed in this, then the FRP doesn't succeed. You're quite right, Claire, to make that point. One question I just want to go ask, which is, how many new beds are we opening?
We are 80.
18, and what's the predicted effect on theatre utilisation of opening those 18 beds?
They're emergency, so there will be new emergency medicine beds, but what that will do is obviously then allow us to
ensure that the patients aren't medically fit who are on sorrel,
No,
which
right.
will allow us to.
No, I understand the
Yeah.
process.
Yeah.
What I'm driving at is what effect will it have on
Yes.
theatre utilisation?
Yes.
The,
No,
the theatres, sorry,
sorry, I don't think we've, so I understand the question, sorry, Claire. In terms of obviously us being able to describe then, if sorrel is fully private, obviously what impact will that then make in terms of our theatre utilisation for private, and therefore, and we'll track the income, so obviously, so we know, for example, changing the emergency medicine surgical beds that we've had open, a surge, making them substantive will have £1 million impact on our agency. So we've tracked that, and we know that the figures associated with being able to then fully utilise sorrow as an elective ward.
and to support what Claire was saying, the trajectory for the utilisation is to go to 80%, between 80% to 85%. The target is 85% actually. The minimum standards, we're sitting at somewhere below 70 at the moment, I think at 65 as an average, but it varies across the specialties. The trajectory is, once we release those beds, the 18 beds, which surgery get the bed back, the utilisation then goes up between 80% to 85%
And when are
over
the
next
18
year.
and then the 18 beds coming on stream?
So that's the, we're
So-
recruiting.
When are the 18 beds coming
Oh,
on?
when, sorry, I didn't hear. So we should get our hands on Clement's second week of November, so I'm just back from leave today, so I just need to check in on.
Okay, so by the December board, we would expect to see a positive impact on theatre utilisation.
Because of the impact, because of the steps that we're taking anyway, obviously we would have 2 weeks of impact, depending on obviously being able to open those beds before then the data, but the data that we'll see at December board won't be been impacted.
No, so you
Yeah.
understand that,
Yeah.
yeah. I'm just very anxious that we are all assured that in opening 18 beds, we actually get the positive hit on theatre utilisation, and that we're measuring that precisely, otherwise we'll all be very nervous, you
Yeah.
and anybody.
And Chair, just to clarify that, and the challenge of course is that whilst we can open beds, the issue is of course staffing. And that's the challenge, is how quickly we can recruit and get those in, and that's really what we're describing.
Yeah.
We want to do that really, really quickly. I would think that it's probably January by the time we see the impact of that.
And that's what you're factoring into your calculation.
It's certainly into our plans, yes, but of course we want to accelerate it and get it.
No,
We have to start coming this month in December.
I'm just picking up Caroline's point, that there are a lot of risks in this, aren't there?
Recruitment being the key one.
Yeah. Okay, thank you.
Yeah, just to comment quickly, pretty obvious point, but I think we need to recall the risks of optimism bias
Yeah.
here over the next period really. But thank you, Olga, for a very clear and authoritative presentation of this really. I think it is very important that we examine what's happened that wasn't anticipated, and think, well, what can we learn from that for next year and beyond, and do a certain amount of kind of scenario planning really.
Good, thank you very much. Right, can we move on and just point out that we're dropping behind our timetable? It's a very ambitious one. Steve.
Yeah, thank you, Chair.
And Steve, if you focus particularly
Yes.
on this.
So there's only 2 things
excellent.
I was going to highlight. One was the recruitment activity, which we just talked about briefly, but you can see from some of the tables there that as well as having the increase in funded establishment across all of our care groups, we've actually got more staffing posts through this year as well, and a step change between August and September, which has had an impact on our vacancy rate. Still got a significant number of vacancies that we're working through, but over the last month we've seen that several of the things that we've put in place starting to bear fruit, along the lines of people coming through specialist recruitment agencies and post-qualified nurses joining us, some overseas colleagues joining us as well. So those multiple strands that we started using starting to bear fruit. As I say, quite commonly to everyone now, one data point doesn't make a trend, and this could just be a bit of a surge because we've got activity going on in all of these areas. But what I'm hearing from the colleagues who are starting to build the pipeline numbers is we still have a significant number coming through clearance as well. So it could be the start of a change in our delivery. And what I anticipate is for the next board to be able to give you more of that pipeline information. How many people we have in clearances, how many people we expect to bring in. As you're aware, Chair, the data sources make that a bit more difficult. The one area that we're still struggling with is exit interviews. So I spoke to the team have been running the offer to do face-to-face interviews with everyone who resigned, and there's been a really low uptake of the information that we've gleaned. It's the things we knew about cost of living and some communication issues and some issues with management, but on very low numbers. But what I'm aware of now, since I wrote this report, which is why it's not in the report, but I can update the board verbally, is an external on Ireland company have been commissioned to contact all leavers and offer them the opportunity to have a conversation independent completely of government. They're focusing on health to start with, so all of our leavers this year will be contacted and be given the opportunity to have that conversation, and obviously we'll get the data and information from that. And also, behind the scenes, the central HR analytics team has now generated a dashboard of leavers information, which will give us richer information on a monthly basis. But that's based on people who filled in the forms. So there's still work to do, and I think it's around people feeling comfortable to come and have those exit interviews and giving them the safe space, and hopefully this external organisation might get some richer information. But the themes continue to be issues of cost, some issues of training, and issues around communication and some management style.
Oh, yeah, thanks for that, Steve. Yeah, pretty obvious point, really. I think the more we can understand about the experience of the people who stay, as well as the ones who leave, you know, the better, really. What is it that motivates people to want to remain and to enjoy or not enjoy working here is helpful.
Yeah.
That is a good one, thank you.
No, that's a good point, Tony, as well. There's always been the intention to start stay interviews. I've seen them run in other places as well. You know, people have been here for 3 years or 5 years or 10 years. What is that about, as well as the leave?
Yeah.
So again, as we get into a better place in capacities and understanding of the workforce, I think we'll introduce them as well. I think they'll be really powerful bits of information. I mean, you know, when you start looking at numbers, we lose. I think over the last year we also had 17 people in the first year. So having that information from them would have been quite interesting about what it was in that first year that didn't meet their expectations. Once people seem to be here 3 to 5 years, then they stay. So there's a significant transition, possibly moving to Ireland, possibly cost. There's a lot of conversations that need to be had to understand that, and hopefully, you know, offering an external source from government will allow people to have that more frank, open conversation, more trusted conversation about what the real reasons are.
I was going to say, I really welcome that. I think that's a great idea that you've instituted to have an independent organisation have those discussions. So really, the next question is, so when will we get the results of that?
So I'm still waiting to hear when they're running it out now. So they're rolling out now the invites to people to have the conversation. So if being honest, see that takes the rest of this year. It's going to be first quarter next year, I would say.
Well, that would be really positive,
yeah,
to be able to see that.
Yes, very much so. Agreed.
Good. Thank you very much.
Was there any other questions or anything else in the report? Yeah.
Great. Thank you. Patrick.
Serious incidents. Serious incidents, but I think obviously it's the monthly report. What's changed since last month is that we discussed at the last meeting appointing investigators. We have managed to secure services of an interim investigator who should be starting with us in a couple of weeks, I think, who will focus on investigations that are stalled or have not started. So hopefully that will make a difference by the end of the year. We've also secured the services of an external investigation company to do a schematic review and multiple obstetric hemorrhage, and that should also be starting soon. That's 19 cases, that's not 19 SIs, but because we're concerned about this subject. All heritage come to the SI panel. I think there are about 6 of those SIs. As the quality and safety team expands and recruits, they're being able to be more active, and they've run their second quality and safety learning event this month. There are over 100 staff attended, with good engagement and good discussion, which is encouraging in terms of changing the culture. And they ran a patient safety week as well. And the recommendations that have come through SIs, end of the report, they have now much greater oversight of those that have and have not been implemented. There are still a lot outstanding, but since August they've been reduced from 320 down to 220, so there's been good progress there. But those are the main things that have changed since last year.
Thank you. Any questions on that?
So I think last time we had the report, there was a difficult, maybe we'll discuss that presumably under the report that we've got on what, I can't remember what it's called, job planning.
Yeah.
But the number of people actually, when we go back into the previous performance report, there was one fall that caused very serious harm to somebody. And I just wondered, you know, how, when something like that happens, which does cause serious harm, do you have any problem therefore getting somebody to take on the role of looking through, you know, of championing or leading a serious incident review?
Somebody having full, not generally for that. I mean, there's obviously a roundtable review immediately after that event, so there's immediate learning from that, and then that would also come to the SI panel to see if there needs to be an investigation as well. So I think there's better engagement at those roundtable learning events, and immediate reviews, so that immediate actions can be put into place and that there have been. But yeah, getting investigators is still overall
A challenge, okay. Well, we can discuss that later.
Just picking up on that point, so SLT is being asked to provide additional payments to clinicians to carry out SI investigations, and I guess that should go to SLT. But my question is, do I think the consultancy have 10 hours a week SBA time?
It's variable, the amount of SBA time that they have. I agree with you. I think a lot of this should fall into SBA time. I think it's an item for discussion as to whether that would be appropriate. I would have reservations about that, which I think you're articulating until we're absolutely sure of what consultants are doing in their SBA time.
Yeah, I agree there's a wider issue that
Yeah.
you're implying.
I think it also has to be remembered that it's not just for doctors to do these things.
No, indeed not. No, I was just thinking, rather than spend more money, when we're already spending quite substantial amounts of money, are we addressing the way that's being spent? And by being more directed about SPA time, I suppose.
Yeah.
Yeah. So, can you think about that and can perhaps you've included it in your job planning?
Yes.
If not today, later, as to I'll come back to it in job planning. Let's move on and come back to that point. Let's just deal with the waiting list, and particularly this question of the spend of money. So we have money to spend on waiting lists. Is that correct?
Yes, we do. It's 5 million.
And when did we have the 5 million?
We've had it earlier this year, and we've forecast to use part of that this year and then the rest this year.
Okay. Don't want to add to that, Claire. I mean, so my question is, what's the difficulty in spending the money on waiting lists?
So the detail of the financial spend is in the the last page of the waiting list recovery report.
Yes.
So I think we were notified of the funding was actually available July, August.
Right.
So we've actually only had since that period of time to actually say, right, you can now proceed to spend money. And then obviously particularly with many of the schemes, there's quite a complicated or certainly detailed complex procurement. So waiting list initiatives that we've been able to do in-house, so for example some high volume lists with our own staff, we can just crack on and do them as we've got staff and we've got beds. Obviously more of the complex ones like the endoscopy outsourcing arrangement that's actually in progress now, obviously that took a longer time to actually be able to then start spending the money.
So how much of the 5 million have we spent?
The majority of the moment, I think we have a forecast to spend about just over 1.5 million of that this year.
Right. So, is that your understanding? So it's 1.5 million we've spent.
So in the projections in the waiting list, we're saying 2.7 by the end of 2023. Obviously, that will be dependent on staff, etc.
Yeah. I mean, I don't know the detail of this, so it might be off the mark. But I suppose my question is, given that we've got very long waiting lists and we've got money to spend, is there no way we can spend that money and get the work done more quickly?
So we are trying to spend the money as quickly
I'm
as
sure.
possible. I don't normally need a lot of encouragement to do that. But it has obviously been demonstrating that we are compliant with procurement processes, particularly for some of the outsourcing or insourcing arrangements. Obviously then we are, once we get the green light to go ahead, then obviously it's on their ability. So it's not just as easy as being able to...
No, I do
and I know you know it's not easy.
Yes, I know that.
Yeah.
But just, I suppose, from you deciding you want to spend money externally to spending it and getting the work done, how long does that procurement process take place?
It depends on the complexity, how many...
But ballpark?
That's 4 or 5 months. The ophthalmology one obviously is ongoing. Endoscopy took probably about 3 months to get to procurement board. So it does take time.
I think this comes back to the point you were making, Claire, about the procurement process, which perhaps it's naive, but seems to be extraordinarily lengthy. In my experience, you could normally procure outside support for waiting lists in weeks, as opposed to months and months. Is that everyone else? Am I the only person that thinks this?
This is, and again, one of those structural interventions that we're looking into. Procurement is a central service, and there are challenges and delays in capacity.
Can you include that in your paper on procurement? Because it does seem to me unfortunate if on the one hand we are given money to spend and yet the process of spending it is so protracted that it's not actually spent. I don't see this benefit to patients at all. Claire?
Can I ask a question, Hugo?
Yes, of course.
So, my experience around waiting lists is that when one starts to look at who's on the waiting list and what else can be done, that actually the waiting list rapidly disappears. I'm not saying to be laissez-faire about this, but a lot of people get better, sadly some die. There are other ways of dealing with waiting lists than just putting people through onto the procedure that they were initially put up on. There's a lot of evidence coming up now about different ways of reducing waiting lists other than putting them through the operation procedure that was initially they were referred for. And I just wonder, I mean, again, it's not for now because we're going to be finishing early today, but whether we could look at this, because there are lots of reasons why people get onto a waiting list. It's not necessarily because they need to be on that list. So it might be that some of that money that's underspent could be used to somebody on the island just to do a quick review of what other places are doing to review their waiting lists and the initiative. For example, group consultations have been found to massively reduce the need for the original reason why somebody needs to be on the waiting list. So it's just a thought if we have got enough to spend.
Good, thank you. Leave that with you, Claire. 2 Claires now. Claire, if you've got thoughts on these processes.
Are you talking to me?
Yes, I'm talking to Claire Gerard now.
Let me have a think about it.
Yeah, would you ever think about it? And any thoughts that you have or indeed anybody else have would be very welcome. Any ideas would be useful.
Okay. What I might suggest is when I come in December is maybe the day before to actually sit and talk, just actually have a look, because there's lots of work being done
Okay. Well,
in waiting lists.
I'm sure.
And, it just might be a way of just dealing with our poor patients that
Good.
are struggling there and deal with them in a better way.
Okay, I'm sure that Claire and others will take you up on that. Thank you very much. So that's the 2 Claires in December. Thank you very much. Right, Patrick. Job plan.
Right, so yeah, the paper is read. There has been some progress in terms of job plans being signed off, and they changed the way we report it slightly because to make it clearer who's actually got a job plan in date. The area that probably concerns me most is the number that are still in discussion. And since writing the paper, I've had a closer look at those, just try and understand why they're not progressing, and I think it's multifaceted. Some of it I think is people just not understanding the process and they need support. There are a cohort of HCS doctors who have traditionally been paid quite high numbers, 17 or 18 programmed activities, and when they're being job plans more accurately within our policy, it's coming out at 13 and 14, and that's difficult for the individual because that leads to a significant reduction in payment, which in Jersey is very challenging. So that's one area that we need to look through. And I think in some areas, trying to get some consistency. People are working the same rotas, but when they're using the system, they're coming out with quite different numbers, and it's trying to understand that. What I intend to do, and I can't give you that sort of timeline at the moment, is to work with my deputy medical director, who's experienced in job planning as well, having more recently come from the UK, to do some focus work and take time out to target people in that area and support the care groups and teacher service and clinical leads, and possibly job planning themselves. So certainly get the input that I want to anticipate over the next month to 6 weeks. Going back to the conversation that we have, in the areas that is really tricky is people's understanding and what they feel is appropriate to do in the supporting programs, activities, the SBA time, how much people should have and what activities they should be undertaking, and indeed where they should be undertaking those. More recently having a challenge of why shouldn't people be able to do those at home, because more and more people are working from home, and that I think is a legitimate challenge, but that's the area that I'm most concerned about, because I can see one's getting signed off by commission, first sign off is progressing. But there are some job plans you can see using the system, people going in multiple times, half a dozen, 8 times to change the job plan and just not moving through the system. And others where they are touched as well. So I think that is where we need to focus to try and progress this more rapidly.
Okay, thank you.
I mean, obviously it's really important for you to keep on with this and to get there. But so where people dispute what their job plan content should be, how does that get mediated and resolved?
So we do have fortnightly consistency panel in the first instance where it can be brought to, and the policy does describe an appeals process. Interestingly, nobody's actually brought forward, I think one actually, brought forward concerns about their job plan when there's been a disagreement. I think what's happening is that just agreeing it and not progressing it, and it's just a something. So that's where we need to push that through, so that it can't just sit in the ether.
Well, just picking up on that. Sorry.
Carry on, you go.
I remember these being introduced many years ago. I mean, it was many years ago, 20 odd years ago in Leeds. And we finished up with about 10% of people in the appeal process. And I suppose I'm contrasting that with here, where it's not being done, and we have nobody in the appeal process. So that the implication of that to me is that it's not being driven to the point where people are either agreeing it or, in all fairness, disagreeing it. So if there's a disagreement, why are we not getting that into the appeal process, as opposed to stopping at some point before we get, because it'll never get resolved with it. If you keep discussing it 7 or 8 times and you still haven't got an agreement, then why is that not going into an appeal process?
Yeah, I think that's actually it, and that is why I think myself and the deputy will personally intervene to try and identify those which
Right.
are simply going around in circles and push them through one way or another.
Yes, otherwise I think it's a board, we're very vulnerable here. We're spending public money, maybe appropriately, maybe inappropriately. The problem is we just don't know. And it does seem to me that we've got to be quite tenacious about this and say that if it is not possible to resolve an issue, for what might be very good reason, then that has to go to an appeal process. There is an appeal process, because the consistency panels are not an appeal process, are they? No, they do something quite different, which is worthwhile, but it's not the appeal process. So I think when you come back next month, it would be helpful to know how many of these issues which have not been resolved in years, not in weeks, but in years, are going into an appeal process. So that from everybody's point of view, the doctor concerned as well as the organisation, the issue is resolved. Does that seem like being unreasonable? Yeah.
No, you're not being unreasonable.
Right. So can you come back on that? Right, thank you very much. So acute medicine, Adrian, I think, lurking at the back. Claire stepped back. Sorry? Yeah, Claire stepped back. Can you handle this, Adrian, or would you rather wait till Claire gets back? Yeah, sure. Go ahead. So just.
Oh, she's back.
Apologies.
Right, okay.
So we can discuss the acute medicine programme. My name's Adrian, I'm Chief of Service for Medicine for those that don't know me. So this is really just to bring to the board an update on where we are. We're all aware of the various reports that we've had from the Royal College of Physicians and others looking at our provision of acute medical care in the hospital. From that, we have generated an action plan. We've summarised some of the actions that we've taken to date for people to read. I'm happy to take questions on where we are and where we've got to get to.
Good, thank you. So in terms of the action plan, does that have timescales attached to it?
It does, yes. The recommendations from the Royal College, they provided recommended timescales, and so obviously we've set the actions and timescales associated with the recommendations from the Royal College.
Right. So that we could see that in terms of the detail and the timescales.
Yeah, and the evidence.
And the evidence next time.
Yeah, we can certainly bring that to the board.
Yeah. So I think that would be really helpful, wouldn't it, to know exactly what is going to be done. I should say that this RCP report, I think, is going to be put on the website today. So in redacted form, so thank you for that. So if people want to read that report, it will be on the website, and I think if people do read it, they'll see why there's some urgency attached to this. So Claire and Adrian and their teams are attempting to deliver what the Royal College has recommended, I think on more than one occasion.
Yes.
Yeah, so there have been a number of reports which have said similar things, and so what would I think be really helpful to the board would be, these are the actions that will be taken to address everything that we've been told, and this is when you anticipate they'll be completed, so that we can get a feel for all of this, which currently, frankly, I don't have at the moment, but I'm sure you do. So would that be okay?
Yeah, absolutely.
I don't get to want to go into it further at this point until we've got that detail later. Is that okay?
Yeah,
Thank you very much. Thanks for coming.
It's all right.
So, alternative, I think. Is you, David?
Sure.
And Patrick.
Thought we can start
so,
here.
yeah.
So, I'm David Hopkins, I'm Chief of Service for the Women's and Children's Division. We provided a brief update report on progress of the maternity improvement plan, which was submitted by Livy, who is our project manager supporting the leadership team in Women's and Children's, with the implementation of the plan, and in particular in providing assurance in terms of completion of the various elements with appropriate evidencing. And in her report, she's just briefly identified the current state of play and the change in this since last month. Just to briefly recap, the improvement plan is a comprehensive plan that takes into account all recommendations made by external reports and by reports into best practice in the UK, and is a very comprehensive plan. We've been working through these through a series of 4 work streams, and as you'll note from the table there, we've managed to shift a lot of these into the green category and to sign off. And where we say to complete, this is where we've established this as business for you and evidence that. So we're assured that we are moving forward at pace with change. And the 3 exception points that have been noted there, the most significant of these remains culture. We recognise that there is need to make ongoing culture change, particularly around stronger multi-professional working within the maternity services. There's been some comprehensive work done by the culture team on this in terms of diagnostic, and we are formulating and initiating a plan for resolution. And we are currently looking at several options around external support for culture improvement in the team. The other elements that are listed as red, the training is in fact started. It's still red until it's fully embedded, but we have an ambitious program of multi-professional training, which is actually just kicking off now, and will develop further over the coming months. This is particularly around skills and drills training to ensure that the teams are working smoothly together for potential emergency situations. The other things still listed as red is primarily about the changes in the structure of the performance reports for all care groups, and particularly actions within our care group is to define the metrics, and we've revised our metrics for reporting to the board and indeed for exception reporting, both internally to the executive team but also to this board, and for external publication. So they're the areas. In terms of those two, the CGPR red is pretty well ready to move to amber, and we'll be moving forward. I say the training will rapidly hopefully move towards green over the coming months, and the culture piece will be a fairly prolonged programme of work which we anticipate continuous improvement over the next 6 months. So that summarises where we're up to with that plan. I'd be happy to take any questions on that. Patrick,
just endorse everything that David has said, and extend my thanks to him and the rest of the leadership team. I think we've been struggling with making progress in maternity for quite a long time, and chairing this particular group. It's over the last few months, we've become much more confident that progress is being made. I think the team are probably their best critics. They will not things through till they're absolutely convinced. And sometimes we would be going, have you not done that? And then they're saying, actually, no, we're not confident. And that's a really step change in what's been presented to us. So I see significant progress. I absolutely agree with David that the biggest challenge we've got is around the culture, and that's interprofessional working. That is, we really have to make a difference to, but it will take time.
Thank you. Well, first, thanks for a really good report. It's very clear, and I think it's worth modelling other reports in this sort of way. But really set out where we are, where you anticipate, where are the problems. So thank you. It's one of the better reports that I've seen. So are there any questions? Very clear. Claire, are you happy? Good, thank you very much. Well, thank you very much.
Yes.
Thank you. Thank you. Good. Infection control. There's only one issue here that I want to pick up on, and that's the vaccination rates, which seem extraordinarily low at first sight. Although I think the point is well made that people may have vaccination through their GPs.
Yes.
So I guess my nervousness is we don't know.
We don't know for those people that don't have their vaccinations
Yeah.
with HCS, but what we do know at the time of writing the report, the rates were low, and the team continue to do visits around the HCS sites, and they've also got a static clinic as well. And from the end of October's rates, the flu vaccine has increased from 13.4% of staff to 25% of staff uptake, and the COVID vaccine uptake has increased from 12% to 24% as of the 30th of October. So the team continue to go around and offer the vaccine to staff in the workplace, but as you say, we don't have figures for staff that have taken the vaccines through their GP.
So two quick questions. One is, do we know what it ought to be?
So we know in comparison to January 2023, so when we did the vaccine for 22 and we ran into 2023, the flu uptake was 34% and the COVID uptake was 14%. So our flu is still slightly lower at this point in time, but our COVID is higher uptake than it was last
Do
year.
you know how that would compare with the UK or anywhere else?
I don't know
You
that.
Well, I think in the UK, hospitals vaccination only actually started quite late, so only a couple of weeks ago, actually about 3 weeks ago.
Right.
So, but normally flu vaccination is about 45%. So,
Right.
yeah.
I don't know what it ought to be, so I don't know to look at the figures and think that's good or that's poor. Intuitively it looks poor, but so do we have a target?
We don't have a target,
So perhaps there are two challenges there. So one is,
yeah.
could we set a target, recognising it will probably be debatable? And secondly, is there any way we can get any intelligence on the number of staff who have been vaccinated in primary care settings? Because that might, if one's not to just be quite a large number of people. And then if from our sources elsewhere we can try and get some sort of benchmarking data,
Yeah.
I think it would be really helpful.
Well, I'll certainly go back and sort of
Would
find
you-
out what
would
the
you
rates
mind?
are of the two hospitals where I'm.
Yes, exactly what the rates are there.
Yeah.
And I don't know whether, Claire, any of your sources would be able to produce a benchmarking.
Yeah, I was just thinking about it actually. I'll try and find out. I mean, I think your first comment, most people get their vaccine from their GP, from health workers.
Yeah.
So, and I just can't remember. I'd have to go back through some old board papers. I mean, what's the overall vaccination rate on the island? I mean, is there a good uptake of the flu vaccine?
We don't have that data.
We don't know, Claire. Well, can everyone just do a bit of digging so that we know? I think our current problems, we don't know whether we're doing well or whether we're not doing well.
I think nationally the NHS has been closer to 70%.
That's the figure I was thought we'd see 60 or 70.
Yeah, I think it has been. I think what we've had is then some difference as with the introduction of the COVID vaccine as well, which tended then impact on the flu, because the flu was over years ago. I can get the data on averages. It normally sits with occupational health departments, and of course we don't have that in Jersey, so we don't hold that data. But normally then you get your information in around who they primary care, as well as and you get data now or record, we don't necessarily have that. But so it might be a like for like comparison, but it gives you a good indication where we want to go. And it would be higher, it certainly be higher than 50%.
I mean, this is absolutely outside my area. If I have any clinical expertise, it's not in this area. But those percentages, I don't think will give herd immunity at all, will they? No. So if we could get... Oh, thank you.
On Google. I mean, Google, it looks like it's very high amongst health workers in the UK. It's running between 70 and 100%. I don't believe 100%. So it's a quick Google.
I think 70 is about the mark.
Right, 75. Right, Jessie, so...
I've got one that says 49 and 42% in frontline healthcare workers.
It's definitely only, I think, in the healthcare workers in outside hospitals and social care, it's below 50%.
So, I think we've got to steer on this. If you can do a bit of digging, I think it would be nice to know what we should be aiming at. At the moment, we're not there, are we? Okay, thank you very much. Andy, safeguarding.
Thank you, Chair. So this is a further update. The original intent was to bring an audit outcome from our safeguarding adult team to this board. People will be aware on head police ones. This is an area of concern for me. The safeguarding adult function for the island sits within adult social care, and we've seen a 47% increase in referrals to the team since the beginning of 2022. With no resultant budget increase in capacity. There are 3 people in the team, 1 team manager and 2 practitioners. So to play to the financial recovery plan discussion, we have placed an additional worker in by moving some money around into the team. But the team is struggling to keep on top of the day-to-day referrals. They're doing so, they report on a regular basis so that I can be assured that we're doing things within a timely fashion. But actually, their capacity to undertake some of the wider safeguarding work is very limited at the moment. So this is being led by the General Manager of Adult Social Care. She is, our original intent was to do an audit around the outcome of some of our adult safeguarding interventions, particularly using the Making Safeguarding Personal Framework, which has been very much supported by the partnership board here. We're not in a position to do that today. I understand from discussion with the General Manager that we anticipate we will have completed the audit by the end of this year. So I would ask to bring this back. Probably February, I think.
Okay.
Thank you for that global update. What numbers are we talking about? The 47% increase is huge. What's that from that?
So in the first 2 months, in the first 2 quarters of the year, we were getting between 200 and 220 referrals into the team in a quarter. So at the end of the year, we were forecasting around 900 referrals into the safeguarding adult team in the year. Now, it is important to understand context. There isn't a Care Act here.
Yeah.
So the legislative framework is quite different in the UK. So what comes into a safeguarding team is not quite the same as what you'd expect to see within adult safeguarding services in the UK. A large percentage of those don't result in further investigation. They just require initial inquiry. But of course the team have to manage all of those referrals and determine whether initial inquiry or full investigation is required. A large percentage of those referrals also relate to vulnerability and self-neglect. So we can provide a more detailed paper on the overarching work of the adult safeguarding team if that would be of use. The team are stretched, there's absolutely no doubt about that in terms of the current demand on them. But of course we're looking to see how we can resolve that.
And can I ask if numbers are increasing in that way, and is that because people are becoming more alert, both people themselves and people who might refer people about them with safeguarding concerns, which is a good thing, really.
I think that's absolutely right. I think that the team have done work, and other parts of the health and care sector have done work around increasing awareness around safeguarding and the need for safeguarding referral, and of course that leads to increased referral into the service. So yeah, exactly as you described.
Thank you.
Thanks very much. Anything else on that? No. Good. So, board timetable. Emma, what are the dates for December and the January boards?
So we have a meeting in December the 6th, and then just let me refer to my paper. The next meeting the first meeting of 2024 will be on the 25th of January.
So that's the next two, and the timetable for the whole of next year will be on the website by...
Later today or tomorrow.
So that'll be all the board meetings for the whole of next year. So thank you very much.
Is it the 25th of January? Yeah.
Yes.
Which is a Thursday.
Yes. It goes to the last Thursday of the month.
Okay, so now we move to questions from the public, which related, of course, to the agenda. We had a question from Jean Elliott. Yes, Jean. Shall I read out the question?
Yes.
Yeah. So, and I think, Claire, you can address this, although I've a slight addition to the question. Why are the social rooms at the end of each ward, which were historically available for all patients well enough to get themselves up and around, not available to patients to use while waiting for their meds, so that the beds they had been occupied could be utilised for the patients on the waiting list? Well, I suppose I'd answer Jean's question. What are we doing to get the meds to the patients rather faster? Because I'm sure you would agree, Jean, that if they didn't have to wait, that would be super.
I've heard of my nephew actually was in hospital recently. He was discharged the morning after his surgery. Well, was told he could go home after the ward round after his surgery, but then was told he had to wait for his meds, and so he sat there, had his lunch, and he eventually got his meds at, I think it was about 4:30 in the afternoon.
Right.
So I mean, that's just taking up a bed all day that somebody could be using.
Sure. So two questions. Can't the patients wait somewhere else, please? And can we speed up getting the medications to them?
Absolutely.
These are the problems you see in every hospital ever been in.
Yeah.
But Claire, yes.
So in terms of the social rooms, obviously, in terms of the social rooms, obviously that's a little bit, but I don't have the, I know I've been speaking to Jessie about that. So I suppose there's a few things. In terms of obviously ensuring that people's medications are ready as soon as possible, as part of the work that we're doing around operational flow, we've very much got the mantra of home tomorrow, TTOs today. So all of our clinical teams, obviously when we've got an expected date of discharge, we know that we are requesting, so the doctors are doing the pharmacy scripts down, and we make sure that we've got the medicine. So clearly, obviously, that's something that we continue to need to improve on. One of the things that we're looking at as well is having either, there's different initiatives around the globe, so home for lunch, or golden discharges. So that's every day us being really clear on who are the 2 to 4 patients that are going to leave the organisation by 12 o'clock every day. So that's particularly patients who we know are on book transport, because we know that obviously that they'll be leaving the hospital at a certain day, and us getting surety of knowing that those patients are leaving in the morning then obviously gives us confidence on beds that we have available for emergency patients. Obviously surgery is slightly different. And obviously we do need to continue to work with patients and families, because often a lot of patients are dependent on being collected by members of the family, obviously, who may be working. So we'll continue to work through those things with patients and families. The social room, so my understanding, and Jessie will be able to comment as well here, so we've actually only got, often in hospitals you have day rooms, which obviously then also provides rooms where patients can wait for either medicines or to be collected. And we've actually only got, there's only one ward, Jessie, correct me if I'm wrong, Beauport, that actually has a day room there. So Beauport. on the surgical floor. So as part of our winter planning, we are looking about whether if we had a discharge lounge, that would allow us somewhere where patients could wait away from the beds so that we get our hands on beds earlier in the day. We do have an area actually on the surgical floor, which is our theatre direct, which allows us to receive patients. They go off to surgery, so we're not actually then, that's part of our theatre utilisation work as well, so that we know that we're not delaying theatre and people going to have their operation, but that obviously then that allows then discharges to occur over the day and then they return to the beds that's allocated. So there's a number of things, but my understanding is those social rooms are not available. They've been either converted into different parts of the estates, but happy to have a discussion with you after the board,
Well, I mean,
Jim.
this was on a surgical ward and he just sat there. He wasn't put anywhere else. He just
No,
sat there.
no.
So specifically, are the social rooms which are available for this group of patients?
Yeah.
They are. The answer is, your question, Jean, is where they are available, yes, they can be used by these patients. The question that's prompted from me is,
They're not available in every
what are we
ward.
doing
Well,
to
exactly.
get?
They're not there anymore.
Yes, there's no need to wait. I mean, there'll always be need to wait, but
Yeah.
if the wait was as long as this particular patient
Yes.
had, then that's wasting their time and wasting
Yeah.
everybody's resource.
Our staff do ask patients to move away from beds, obviously, if they're waiting things, but we don't have day rooms and areas where patients can wait on every ward,
Right.
which is obviously
Okay.
something.
But it doesn't have to be on their ward. Can there not be one room for the whole
No,
hospital?
I think that's what Claire's addressed, which is
About the
the way
discharge
this is
lounge.
done is either on the ward, and we've agreed
It
to
seems
use
such an easy fix. And the other thing, which I did read the question, so it's going to be addressed by Chris. I don't understand why they have to wait for their meds from the hospital pharmacy. Why can't they just be given a prescription and get it from their pharmacy anyway?
Patrick.
That would make absolute sense. Unfortunately, the way the funding works, it's in order for a hospital doctor to write a prescription that can be taken to a community pharmacy, they have to be on a prescriber's list, and that's why the GPs can do it. The authority to allow that does not sit with HCS. It sits with Customer and Local Services, and that money would then come out of the HIF and transfer it to the costs. We have looked at this because we looked at it for the academy and seeing, because we think it would be cheaper, but I looked at Claire, it was going to be significantly more expensive for us if we paid community pharmacies to do that, and given our financial position, it was not something that we supported, but I was against that.
I mean, the key
Can I
thing
just add something? Sorry, can I just add something? I mean, because what I'm hearing is the computer says no.
That's
So we've got a patient who's hanging around post-op hours, and we have to sort it, because I do understand it's the shift of funding. So, and you certainly don't want them to have to go to the GP immediately post-op, but there has to be a way of being able to issue a community prescription, or for the whole system to be speeded up. And I think, to me, this is the crux. You know, you've got a patient who's sitting waiting because the system hasn't designed itself around the patient. It's designed itself around the system. And if we're going to be, as non-executive directors, of use at all, it's to bring these sort of examples as real life examples to say this is what makes a difference to a patient. And so we have to make sure it works for the patient, not for the system. Sorry that I'm saying that, but...
No, you picked up exactly on the point that I was beginning to drive at, which is, I think the reason that the delays occur is, as ever, multifactorial, and I'm going to ask somebody to bring a paper back which lists the factors, because some of them I suspect will be on the ward, some of them will be in pharmacy. There's just been pointing out, some are related to the extraordinary funding arrangements that one sees here, which actually get in the way, in my view, of patient care. And I agree with you, Claire, that we should say that and say it publicly. So if simply by altering funding arrangements we can improve patient care, then why don't we do it? And that's a point that I think we as a board want to make to the powers that be. So thank you that, and thank you, Jean, for raising the issue. Any other questions? The lady first. Okay.
One of you were saying, one of your points was that you've got £5 million to address the waiting lists,
Yes.
and you spent, I don't know, £1.5 million,
Yeah.
and you intend to spend the rest before perhaps towards the end of the year. I just find it strange that why do we not outsource? What incentive do you give your surgeons, etc., to do more work in the health department? Because I know that they are allocated so much time to health and then they are allocated so much time for their own private work. Why can't we use the facilities which are only across the water, have an arrangement with France and go to Rent Hospital or some other major hospital there? If you've got such a mountain of work that you've got to do here, it's a logjam. You just don't know how you can't do it. It's months and months and months. But in the meantime, those people that are suffering, we all know that they're the ones. I know people that have actually gone to France, had things done. They may have even gone to England. But why can't outsource more?
Is your question why don't we outsource care from international settings?
Yes.
Good, thank you. I think we've in part dealt with that, and the answer that I think I got to your question, I asked the same question, was that there is a significant procurement issue here. And what we've asked for, so is that the information comes back to this board on why it's taking, what are the factors that mean we are failing to spend the money we've been given in order to get people seen. So we don't know the answers to that, but a paper will come back to this board and will be in the public domain, which will address your very reasonable question. Is that okay?
Thank you.
Thank you very much. Yes.
I think my question covers most of your numbers. I have been going to see a junior consultant who couldn't find my results of a test, who couldn't make a decision. So basically that appointment was a complete waste of time. Somebody else could have used that appointment. I needed to see the top consultant. I had to say I was going to do a DIY job on myself in order to see the top consultant. I shouldn't have to do that.
Okay.
I'm in this chair because of a consultant in Jersey.
I think you're addressing your particular case, aren't you?
No, what I'm saying is, I was told there was no appointments.
Right.
After threatening to do a DIY, I was able to get an appointment the next day. So don't tell me there's no appointments.
I'm not telling you anything, I'm trying to be clear about
And then,
your question.
sorry, I was then sent to Andy Weir's team for safeguarding, so that was another waste of time. There just seems to be a lot of wasted appointments, which is why waiting lists are so long. You know, I'm going to go to pre-assessment next week. I'm going to have a CT scan. I'm probably not going to get my operation until March, April next year. So I'll have to have all that done again.
Well, my suggestion would be that I ask Patrick or Jessie to talk with you individually at some point. They can't talk immediately because we've got another meeting after this. And to try and answer your specific questions about your situation.
It's not just about my situation. What I'm saying is that it's not just me. There are people that are having these appointments you go along to, they can't find your results, they can't find this, it's on the system, they've been lost. So that it's a wasted appointment. You go to a wasted test because you then got 6 months down the line they want you to come in for an operation. Oh, the tests are out of date, you've got to go and have this again. It's just wasted time, wasted money.
I do take your point, and I think what I'm asking my colleagues to do is to look at your case specifically with your condition, to see what we can learn, with your permission, to see what we can learn from it. So why did this occur? Yeah? Because there's a lesson in that for the organisation.
Well, I've been through hell and I still haven't learned, so...
Yeah.
And I'll just say that this is something that I hear quite often from people.
Second, I was second that.
it's not votes. Would you be happy for them to talk with them?
Well, yeah, because,
So
you
that
know,
we can look at the specific,
being disabled and trying to get out of Penrose now for a pre-assessment,
it's
which can be
very,
done in the town where you've got to go for the operation anyway,
no.
is absolutely ridiculous.
But you're happy that one of these two contacts you and gets the
Yeah.
detail, yes?
Oh,
And then we'll see what we can learn from it.
yeah.
So thank you for that.
Chair, I'm happy when I'm next on the island to meet, because I think these again are the crux of the matter.
Yes,
You know, because the lady's right, if there's a 3-month delay between a pre-assessment and her operation, she has to have all that done again.
absolutely.
So again, I'm on the island in December, very happy. These are the sort of things I think that the non-executives need to be identifying, because these are the real issues, rather than the charts that we've seen, which can sometimes muddy over what some of the real issues are. And this is money. It's her money, her time, but it's also the hospital's money if these tests have to be repeated.
Right, thank you very much. What date will that be? December the
5th and 6th.
work is on the 5th. won't it?
Yeah.
So, did you hear all of that?
Yeah.
So, Claire Ferrara is a very experienced and eminent GP who works in London. She'll be on the island on December the 5th. And she's happy to come and talk with you.
Yeah.
Yes? Would
Yeah,
you-
I'll
would-
pass.
would
I
you-
emailed them last night, so I'll pass
Okay.
them the details.
Good, thank you. Thank you, Claire. Right, we must move on. So, thank you, members of the public. Thank you for attending. And the next meeting is on December the 6th. Thank you very much.